All right, so we are back here to talk about diuretics. So we are going to talk about a couple groups of diuretics, and with each group, we are going to talk about where it acts on the kidney, therapeutic uses, side and or toxic effects, advantages or disadvantages, cautions with each of the groups. So the types of diuretics that we're going to talk about are the thiazides, the loop diuretics, the potassium sparing diuretics, and then we'll briefly mention osmotic diuretics, but they are not used all that frequently. So starting with the thiazide. So remember, all diuretics share a common mechanism of action, being they all inhibit ion reabsorption. And they are all going to directly or indirectly inhibit the reabsorption of sodium. And that's where the diuresis comes from. The water stays with the sodium. So the more sodium in your renal tubule, the more diuresis you get. And that's kind of the summary of how they work. So hydrochlorothiazide, chlorothiazide, these are drugs that are used a lot. They are going to act a little bit on the proximal tubule and also on the top of the loop of Henle, beginning of the distal tubule. They're used the most commonly because you can use them orally, it's easy, and they're pretty safe, and they're effective over long periods of time. There's not a whole lot of known toxicities, and they don't tend to cause too much electrolyte or acid-base imbalance, although they still have the potential for doing that. All diuretics can cause electrolyte and acid-base imbalances. So how the thiazides work at the proximal tubule is they're going to inhibit bicarbonate reabsorption and also sodium ion reabsorption from the ascending limb of the loop of Henle, but they're not very potent. And that sodium has the opportunity to still be reabsorbed downstream. So you don't get a lot of diuresis from the proximal tubule. But they do also act on the distal tubule or the loop of Henle as well, but they don't act super potently there. They do get some action as well. So they get a little bit more sodium ion reabsorption there. And depending on the book that you're reading, some books only talk about them acting at the loop a little bit. Other books talk about them at the proximal tubule. Some books talk about them in both places. And in reality, they seem to act on both places. But they are not super potent. They're not inhibiting a whole lot of sodium ion reabsorption, and therefore they're less likely to cause acid-base imbalances. And you can see that bicarbonate loss is balanced by the hydrogen secretion and the chloride loss, and so overall it seems to not be a big deal. But there is some potential for potassium or chloride depletion. And if that's the case, you can supplement them with potassium chloride. Another thing that's interesting about thiazides, and it's kind of unknown why exactly this happens, but they do seem to relax smooth muscle of the blood vessels some. So you get this vasomotor effect, which is really helpful because a lot of people with diuresis have, a lot of people that need diuretics because they have high blood pressure. If you remember when we talked about blood pressure, diuretics are usually first-line drugs for hypertension. And so this benefit of getting rid of some of the fluid and also relaxing the blood vessels, the smooth muscle of the blood vessels, help a lot. All right, so there we have it. That's how the thiazides work. Therapeutically, why are you going to use them? You're going to use them for hypertension, first-line drugs for hypertension. Someone who's retaining a little bit of fluid, they're safe. If someone has acute pulmonary edema, you're probably going to go with something stronger, but you could use a thiazide because of the vasomotor effect. They're safe in pregnancy. Remember that. Of all the diuretics are the only ones that are safe in pregnancy. They are not teratogenic. The loops are. So you can give this to pregnant women. Remember, a lot of pregnant women have edema, and so these can be quite helpful. They are not likely to cause too many electrolyte imbalances, although it is possible, so you got to watch for that, as well as potentially thrombocytopenia, which is a decrease in thrombocytes or platelets, and also jaundice. There is some potential that thiazide diuretics can decrease placental hormone production. So that is one issue. And another issue you can see is that moms seem to have a greater tendency towards high blood glucose. and therefore might not go into labor as readily if they're on thiazide diuretics. And we do know that high blood glucose in the mom sets the baby up for blood sugar problems later on, so that would be something I think is very valid to consider. And always, again, our sort of rule of thumb with pregnant women is if you can do something other than a drug, that would be a better option. The side effects of thiazides are not super big deal, but there are side effects: weakness, fatigability, abnormal sensations. Usually those are probably due to any electrolyte imbalances. Some mild GI symptoms, nausea, cramping. Potassium depletion is a possibility if somebody has hyperglycemia already. So if they're diabetic, that might get worse if they're on thiazide diuretics, and we don't really know why, but it looks like they might inhibit the secretion of insulin. People on thiazides tend to have higher levels of uric acid in their blood, so if they have gout, that's something to consider as well. And you can see that uric acid is secreted actually in the proximal tubule, and the thiazides actually compete for the same secretion site as uric acid. They're sulfa derivatives, so it's not uncommon for them to develop, for people to develop skin rashes if they're sensitive to those agents. Okay, so those are the thiazides. They're used a lot, they're pretty safe, they're safe in pregnancy. They produce a decent amount of diuresis, but not crazy amounts. Here's the crazy amounts of diuresis, the loop drugs. So in bold, furosemide or Lasix, you're going to know those names. You're going to know the category loop drug. You're going to know the name furosemide, which is the official name or the generic name, and you're going to know Lasix as a brand name. These drugs are super powerful. Of the loop drugs, there's 4. The only one of the 4 that shares that vasomotor effect is furosemide. And it turns out the furosemide is actually a type of a thiazide. And so because it's a type of a thiazide acting more predominantly on the top of the loop of Henle, it also has that vasomotor effect. So these are super powerful ion reabsorption inhibitors. So they block that big chloride sodium transporter that's at the top of the loop of Henle, where, if you recall, I said this is where 20% of our sodium gets reabsorbed. So even, blocking just a couple percent of sodium ion reabsorption produces huge amounts of urine. We're talking about like liters of urine in short order with these drugs. They're really powerful drugs. You can see Lasix is 8 to 10 times more powerful than other thiazide diuretics, and it can cause up to 4 liters of urine to be formed within the first 4 hours of administration. Remember, a normal urine output in a day is about 1.5 liters. We're talking about the drugs causing 4 liters of urine production in a couple hours after administration. These drugs move a huge amount of fluid. So why would you want to give somebody furosemide or Lasix? Well, if you need to give them you need diuresis to happen fast and effectively, this is it. These are emergency drugs. So someone's got congestive heart failure and they're just totally congested. Furosemide is given. Lasix moves a huge amount of fluid. If someone has acute pulmonary edema, Lasix is going to be your go-to because it moves a bunch of fluid and it has the vasomotor effect. Someone has acute, malignant hypertension, you might give them furosemide, but you're really only doing it because of the vasodilatory effect. And it will remove a huge amount of fluid, which makes the blood pressure go down, but they can't stay on this for very long, so that it's not the end game. Chronic renal failure. Without getting too into the renal failure, so basically, when somebody's kidneys are failing, they're not able to move fluid through them at all. And so when the kidney is 80% impaired, it's oftentimes necessary to use a drug like furosemide for a short period of time to kind of flush through, remove a bunch of fluid from them because they can't get rid of it otherwise. With furosemide and all the loop drugs, serious electrolyte imbalances are common. And the 2 main ones are potassium depletion, right? Because remember, again, this is kind of the key to this whole thing. If you block the top of the loop of Henle, a whole bunch of sodium is going to land in the distal tubule. That sodium is going to get reabsorbed in the distal tubule. Potassium is going to get secreted. Hydrogen ion is going to get secreted. So both potassium and hydrogen ion are going to be depleted from the blood, causing a hypokalemia and a alkalosis. So it's really common on loop drugs for people to be potassium depletion and be alkaline. Dehydration, obviously, and hypotension are real possibilities because you've just moved 4 liters of fluid in short order. And the other thing about loop drugs, furosemide and all the other ones, and I should say all of the loop drugs are going to have these same special cautions. The only thing different between furosemide and the other 3 loop drugs are that furosemide's the only one that has that vasomotor effect. So for people with acute pulmonary edema or hypertension, that would be your go-to. But for all the other purposes, you can use any of them. They all have the potential to cause either temporary or permanent deafness, which is kind of like, temporary doesn't sound so bad, permanent sounds pretty bad, and you don't really know. And that's because you lose so much fluid, including the fluid in your inner ear, right? That's the crazy inner ear. Remember how that insanity that happens in there, right? If you lose the fluid in there, you're not going to be able to hear anything because everything, balance and otherwise, all of that cut wires a fair amount of fluid in the inner ear. All right, so the other loop drugs are called ethacrynic acid or edecrine, bumetidide or Bumex, Furosemide or Diamox. These are loop drugs. They are just like furosemide, but they do not have the vasomotor effect. So they act the same way. They're going to inhibit a little bit of sodium ion reabsorption from the proximal tubule, but that's not very important. The important thing is they block that big co-transporter at the top of the loop of Henle in the same way furosemide does. So they're going to be used for similar therapeutic uses with the exception of the vasomotor effect. So if someone's got a lot of edema, including heart failure, they're just as effective, but they don't have that vascular effect. So they're not specifically good for treating hypertension or acute pulmonary edema. The cautions are the same, right? There are, with all loop drugs, the side effects, the effects tend to get worse with chronic use. They become more and more toxic. Dehydration and hypotension, again, hypokalemia and alkalosis, that's the same as with furosemide. Deafness, temporary or permanent, same as with furosemide. And again, they are on and out pretty quick. So they have a pretty short duration of action, not short in terms of minutes, but in a couple hours. So they work very fast to move a lot of fluid. They kind of peak at about 2 hours, and then about 6 to 8 hours, the diuresis is gone. So it's not like forever. So oftentimes these loop drugs will be used to move a bunch of fluid kind of on, a temporary basis, and then you send them home and manage them on a thiazide. Would probably be the way to go. Sometimes you'll get myalgia, which is muscle pain. Carbonic anhydrase inhibitors, honestly, I don't think anyone ever uses these as diuretics. We talked about them a little bit with glaucoma, but they're really not going to be used for diuretics. They can maybe use for seizures, maybe for altitude sickness. So don't worry about those at all. The potassium-sparing diuretics, however, now these are the ones that are not very potent on their own, but they're going to chase the symptoms created by the loop drugs. So this is where we have the aldosterone antagonist, which is spironolactone, right? Actually inhibiting aldosterone. So you've got to have aldosterone there. So if someone doesn't have aldosterone, like they've got no adrenal glands, you're not going to find a lot of people like that around, but you might. Or you might find somebody with Addison's disease, which is an atrophy of the adrenal cortex. It's an autoimmune condition, and there seems to be on the rise across the board. So that might be something to think about. But, however, they have to have aldosterone. That's the deal. So what spironolactone is going to be used? How it's going to be used, I should say, is it's going to be used in combination with a thiazide or a loop, and it is going to help to manage those side effects. Because by blocking the reabsorption of sodium in the distal tubule, you're also blocking the secretion of potassium and hydrogen. Not totally, but somewhat. So that would be helpful. So they're retaining potassium, so you have to kind of think about that. And so it's, again, you wouldn't want to give somebody a spironolactone on its own because they would retain potassium. spironolactone is interesting. It's also tends to have a hormonal effect. Sometimes spironolactone is actually used for women with polycystic ovarian syndrome to sort of deal with the androgen excess. And so by antagonizing the androgen, it seems like it produces kind of an excess estrogen-like picture. And so as a side effect of spironolactone, we might see some gynecomastia, which is enlarging of the breasts, which on women, I don't know if that's that big of a deal, but on men, it's not super desirable. Okay, so that's spironolactone. There's some other potassium-sparing diuretics, triamterene and amiloride. They're very similar, but they are going to work independently of the amount of aldosterone in the system. They antagonize the receptor. But they are used the same exact way, right? In combination with a thiazide, and they have the same issues. So they have combined triamterene, which is aldosterone, potassium-sparing drug, and hydrochlorothiazide, and they put it in a drug called Diazide. And that's kind of an interesting thing. So it sort of deals with the symptoms. Sorry. Okay, so the thing about Diazide, because it is a thiazide, we have to think about the uric acid situation and potential elevation of blood glucose. And of course, because it's a potassium-sparing drug, we also have to think about potassium retention. Okay, so the last ones here are the osmotic diuretics. The osmotic diuretics are mannitol or urea given parenterally. You can give somebody some sort of sugar orally, glycerin or isosorbide. In all cases, those things are not absorbable. They don't move from where you place them. So they're osmotic diuretics. So they're used to load up the body fluids with sugar and pull water into them. So wherever you put it, you're going to pull water out of a compartment and into that now super concentrated area, hypertonic area. So these are the ones that are good to withdraw water from overhydrated cells, especially the brain or the eye. They're also pretty useful if you run them through the renal tubules to just maintain a high volume of urine. If somebody has had is experiencing shock, some kind of a toxic, like a bacteria, sepsis, those kinds of things, they're hemorrhaging, anything that's potentially causing blood not to flow through the renal tubules, an osmotic diuretic would be useful. If you're trying to flush somebody's system, if they've overdosed on barbiturates or salicylates, or anything else for that matter, you could flush them with an osmotic diuretic. These drugs are not going to extract abnormal amounts of fluid from the body like we saw with the loop diuretics. So they're just they're sort of reorganizing the fluid. So they're not good for edema because they don't eliminate sodium ion. They're just eliminating water. Okay, so you're going to be cautious with heart failure, pulmonary edema, severe hypertension. For all those people, we'd want to use an actual diuretic. And there is an issue with these people that you have to kind of think about potentially overloading their circulatory system with fluid and causing their blood pressure to kind of go up transiently. So if somebody has risks that you wouldn't want to increase their blood pressure, that would be something to think about. All right, so osmotic diuretics are not real important ones to know. I'd like you to just know the bare basics about osmotic diuretics, but really focus on the thiazides, the loop drugs, the potassium-sparing drugs. So after the last little part of your book talks about some common electrolyte disturbances, which I don't historically talk about in this class because it doesn't really play in for pharmacology. But if you wanted to kind of look through it, you can. This is a topic that we talk more about in like a pathophys class. I think we've talked enough about the pertinent electrolytes in reference to the diuretics. So I'm going to stop this video here, and you will not be responsible for the content in that last section, that last couple pages. All right, I will talk to you guys later. Next unit is Unit 10, which is serums, vaccines, kind of immunology a little bit, hormones. I think that's about it. Oh, drugs for osteoporosis as well. Okay, talk to you then.